The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to today's Safe and Calm webinar. This morning, before we get started, we want to take a moment to recognize and honor our veterans today. They have, over the course of our history, been on our front lines and even helping our member facilities during this pandemic. We want to put out a special thanks to the Michigan National Guard for all their work and all of our veterans today. So this morning we're starting with our routine agenda. We don't have a lot of new guidance to review, but there are two specific updates that have been made by MDHHS, basically for reimbursement for testing and visitation. So we'll take some time and go over those pieces today, along with some other brief guidance from CDC and others. So we'll turn the presentation over to Dalton, who's going to provide a very brief update on what's going on in Lansing.
Good morning, everyone, and welcome to this morning's call, and thank you to our veterans for serving our country. As you will have noted, today's presentation will be, at least for my section, will be fairly brief. As I mentioned last week, just kind of touched on it, we will be moving into a lame duck session with the legislature, which is the period in time after an election but before the next set of legislatures kind of comes into town and they take over their newly elected roles. This does have an impact, as every couple of years, bills are set to sunset after December 31st and before the transition of these new lawmakers. So what this means is that any bill that has kind of moving its way through the process that has not been passed yet will need to be reintroduced during the next session in order for them to be passed. So essentially all the bills sunset, and we'll have to start over from square one on some of these bills. A couple of the outstanding bills that are out there for us to keep an eye on, and that we are keeping an eye on during lame duck, because sometimes lame duck can be incredibly active, but because of Michigan's divided government, we don't expect many major kind of controversial things to get done, but we do expect some things to get done. A couple of the bills we're watching through the process are the nursing home camera bill, which we've talked about. That's not fully through the process and passed yet. They have been talking about running some bills to provide further liability protections for long-term care providers. The medication aid bill is still moving through the process. There's some bills for nursing license reciprocity with Canada and other states, such as joining the Nurse License Compact, that are still not passed. And then there's also a bill that has been coming up for that would require AAAs to fingerprint their employees. This is my important date slide, just a reminder. These are all the same ones from last week, so please keep these dates in mind when you're planning your future decisions. The next one is the deadline coming up for MDHHS and Laura to give us guidance regarding dedicated units in the care and recovery centers for COVID positive individuals. That deadline is November 15th. So we should be seeing some sort of guidelines or rule set come out of the department in the next 4 days or so.
All right, thank you very much for that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. As of right now, we have no questions, so we can keep moving on.
Okay, well, thank you, Dalton and Blake. Let's move on to take a brief look at some of the numbers this morning. So here's Monday's data. At least this graph is updated as of Monday's data. And this is, again, the updated 7-day rolling average of new cases. Unfortunately, we can see a huge increase of cases that continued over the past week. So transmission is growing significantly. The white arrow there is pointing to where the case number was from 1 week ago today. So you can see that not only have we far exceeded the April peak, but we are continuing to grow upward. Also looking at the 7-day average number of daily deaths, we can see that there's also been a steep increase over the past week. And again, the white arrow shows us where we were 1 week ago today. So although we had remained fairly flat during some of the recent surge, for a while it does appear that the deaths are also on an increase. The real indicator of how we're doing in terms of COVID transmission is really the test positivity rate. So although the number of tests conducted may be growing, when the percent of those tests are positive is also growing, is a sign that you have more transmission. So these data cover the daily positivity rates from October 1 onward. And you can see that we are also getting into a high surge time. These next few slides are a bit odd looking. They're going to look odd for a while because at this point we only have 2 data points. But now that we have routine weekly daily case node numbers that are now published by the department, we're going to be monitoring caseload for nursing homes specifically on an ongoing basis, not just cumulative. And also now HFAs and AFCs are also reporting. So this graph is for nursing homes only. And at this point, 100% of Michigan nursing homes reported last week. And you can see that the number of new cases from 11/2 to Monday 11/9 went from just over 300 in nursing homes to 500 this week, 500 new cases during the past week. Now, HFAs only have a 62% reporting rate right now. And you'll see a really steep incline here, but that incline is not meaningful because there were not enough reporting the first week. Remember that November 2 was the first published reporting date. But over the past week, they experienced over 50 new cases. And again, the contours of these slides are going to change as we get more data points. This last graph kind of looks the same. It covers AFC weekly reporting. At this point, only about 37% are reporting as of this last Monday. And AFC's experienced 13 new cases in the past week. And again, the contours of this are going to change over time. So as usual, we're going to take a brief look at the MySafe Start map. It's still generally pretty purple. Note, though, that the statewide test positivity rate has now risen to over 10%. On an individual county basis, remember that if your CMS county code is red, remember that link to the CMS Excel file, that generally means that you have over a 10% average positivity rate. And nursing homes will have to start, if they're in those counties, to test weekly, twice weekly. So we have reached a 7-day average of overall about 3,500 new cases each day in Michigan. That's quite a bit. And currently there are 20 Michigan counties listed as red, meaning twice weekly testing for nursing homes. They're listed as red on the CMS County Positivity Rate file. So also on Monday, the CDC reported a study of COVID readmission data, which noted that 9% of persons hospitalized for COVID were also readmitted within 2 months of their discharge. But there were really no surprises here. The risk factors for readmission were highly correlated with health situation, comorbidities, etc., age. So those frail persons are more likely to be discharged to nursing homes, more likely to go home with home health care, and those are the persons who are also most likely to be readmitted to the hospital for complications. Okay, so now let's move on to a review of new guidance and resources. This is a brief update on payroll protection loans. The Small Business Administration must now publicly disclose all of the PPP loan, who they were provided to, and the dollar amounts received. Before, you just had to hit a certain threshold, but now all of them are going to be published. They also have issued a questionnaire for entities who may have received $2 million or more in loans. All loans at that level are going to be audited, and that audit will occur before the loans are forgiven. And there's a specific survey form for not-for-profits. We're not sure that any members would have received a $2 million loan or a loan at that level, but just in case, the link is here on the slide. Leading Age is working through the process with HHS, going through the requirements, and they're going to be providing a summary shortly for some of these new updates. Provider relief, provider grant relief funds, phase 3. We do know that the application for these phase 3 monies, the application was due on November 6th. And once the TIN for that application is validated, members have until November 27 to submit their financial information. We know that this process has been pretty messy. Members who may have had any difficulties should consider calling the provider support line. The number is listed here. There were some healthcare entities whose application were held up because some of their phase 2 applications were in limbo. Additionally, there may be some remaining funds after the phase 3 distributions have been made, and HHS will be deciding soon on how to use that money. Also, HHS did hold a conference call describing the current process and any changes, and the link to that recorded call is here. Also note that on Wednesday, November 18, Leading Age Michigan will be holding a webinar with Plant Moran on the updated reporting requirements for the provider relief grants. So CFOs might consider attending. These requirements have morphed over time, and John Lonzak from Plant Moran will be discussing all these nuances for us. HUD has released 2 online databases for COVID-related assistance programs. These are programs by state that can help members address needs for consumers who may need some relief, and perhaps some facilities that may need some relief. Those databases are included in the Leading Age link here. Last week, the CDC issued several updates on COVID vaccines. We're not going to go through these in detail, but there is a general list of resources included, a page that lists all the benefits, and a frequently asked question document. And of course, all those links for anyone who's interested are on the slide. Additionally, the CDC has updated its precautions for daily activities with a focus on safety when going out in the community. And this could potentially be a good resident education piece for people who are going out in the community and others. Additionally, they have updated their guidance on COVID antigen testing. CMS is currently working to expedite any remaining review for all of the CLIA applications that they've received to date. And CMS will allow a laboratory, and this is just during the pandemic, to extend its CLIA certificate to other site locations, and nursing homes would be included in that if needed. So if you were a nursing home that had a relationship with a hospital lab or some other lab, it's possible that that lab's CLIA certificate could cover you if you develop an agreement with them. So this web page that's listed here includes also some resources on collection procedures, and that information is not just about obtaining the sample, but also some operational issues related to point of care testing as well. So it seems like a good resource for our members. The Federal Drug Administration this past week also issued a new note on false positives for antigen testing. They pretty much noted that false positive and false negatives occur with all testing. They have issued a few recommendations designed to minimize the risk for any false positives, and we've listed them here for you. Obviously, you've got to follow the instructions for using the test, utilize confirmatory testing when indicated. Make sure that you time the reading of the test accurately. Apparently, that has been a huge issue. You must read the test at exactly the time that you're supposed to. Otherwise, you're likely to get an inaccurate reading. So it can't be too early and it can't be too late. And you must make sure that the cartridges or cards are stored properly. They should not be open anytime before use. They have to be sealed up to the point of testing. In addition, the FDA is reminding providers that all suspected false positives or false negatives must be reported to the FDA and the manufacturer. We've included the link for that at the bottom of the page. The FDA also refers providers to the guidance for nursing homes for use of antigen testing, and that guidance, of course, can be used by HFAs and AFCs, and that link is also provided here. And they do remind everyone that confirmatory testing is really important to understand how to do that, and they refer people to the CDC flowchart. And we've discussed that flowchart several times. Now a very brief update on the Pharmacy Partnership Program for COVID vaccine administration. Part of a dilemma that's occurred is that there has been no confirmation to anyone who may have signed up for this. So providers are a little concerned about where their status is with the CDC. So the CDC is in the process of sending information to each state about who has signed up for the program and who has not. So we may be getting some more information soon about that. And there's also some information on resources for vaccines that they put out as well, and that is at the link on the bottom of the slide. Nursing homes must report point of care test results on the NHSN site now, and this has been kind of a complicated process. There are slides for the training sessions held so far, and we have included them as a handout this morning as an attachment that should be on your screen. There is other key information on the Leading Age website as well, and we've included that. Leading Age does continue to find that this is a burdensome process, and they are trying to work with HHS to figure out that there might be a better way to perhaps batch some of the reporting, so it might be a lot easier on facilities up front at least. We also know that there are a lot of questions about the NHSN reporting, and CMS and CDC are aware of that as well. So they're holding 2 more training sessions, and they'll be on Thursday and Friday of this week. The registration link is here. And because this is such an intense, complicated process, and we ourselves don't have any experience with reporting through NHSN, we're not going to be able to answer questions about this at this point. But we do encourage members who have questions to continue to try to review the updated and new webinars Thursday and Friday. And there is also a link to the CDC for any questions or issues you may have. And know that Leading Age National is also working on looking at the process and figuring out where the difficulties are. Each week, Leading Age Michigan gets a lot of questions. And we got 2 that we thought were particularly important that MDHS responded to. And we wanted members to be aware of these. The first is about the potential new rules concerning care and recovery centers and dedicated units. You will remember, and Dalton spoke earlier about the recently signed legislation that identifies new parameters for these care and recovery centers, and also for cohorting COVID-positive residents in our member nursing homes. Because nursing homes will have to meet certain criteria and get department approval for their units, we were unsure if facilities could just start a new unit at this time, because there's a law in effect that says you have to get MDHHS approval, even though the rules have not yet been issued. So also remember that the rules are not even due till November 15th, and we believe that it's probably going to be a challenge for MDHHS to meet that deadline. But in the interim, the department has responded to us that facilities can work to continue to create units as they see fit, with processes and procedures to deal with COVID-positive residents. So that's really good news. And we hope that there will be some sort of grandfathering / transition process for all of those units that are currently working in our facilities to house our COVID-positive residents. So also, we had a member yesterday who was concerned about access to their facility by COVID researchers, when in general the transmission rate has been so high and the positivity rate has been so high that in many parts of the state, visitation has essentially been shut down. But the department responded that they consider these researchers as if they were medical providers, and they should have the ability to access the facility regardless of the facility outbreak status or the local county transmission rate. Also, one of our members found a state public health resource for facilities who may need help in getting testing supplies and other assistance. We've included the name and contact for Jake and Wilkinson here, and he's in the public health portion of MDHHS. And there's also a link here to help order supplies. And this process, the member told us, is easier to use than the Excel documents. So here's some additional resources for members. So before we move on to the recent MDHHS guidance on visitation and testing, let's see if there are any questions.
All right, thank you, Deanna. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. We do just have a few questions. Regarding the PPE questionnaire from SBA, our understanding is that these were drafts. Have they now been finalized and released?
I am not 100% sure whether they're drafts or not. We did receive them from Leading Age, so I assumed that they were final, but I will check into that.
Okay. If we have a resident who tests positive, but there is no available hub or CRC, and they are asymptomatic and the hospital will not take them, are we able to have a COVID-19 unit to care for this resident without being a CRC or hub?
Yes. In the interim, before the rules come out, you should be serving your COVID positive residents as best you can. And if you have a dedicated unit, that will be fine. When the rules come out, we'll have to see what the requirements are for you to transition perhaps and get approval from MDHHS for your unit. But as of right now, nothing's really changed according to the department in terms of how you must deal with your COVID positive residents.
Any insight about why testing is not required for state surveyors?
I don't have any insight. I don't understand it. Let's just say that. No, I don't. And that's part of our advocacy on an ongoing basis. It's also part of our Leading Age Nationals advocacy. We don't understand it. We think it's highly inappropriate and actually could potentially put some of our residents at risk as surveyors enter our buildings, and they enter multiple buildings. And as we all know, we're surging. So we have a problem with it. And we think that that Robert Gordon, who is the director of MDHHS, understands our concern. And at this point in our discussions with him, he has promised to address the issue with Laura. That doesn't necessarily mean he's promised to fix it in any way for us, but he is at least looking into it.
I will add, yesterday during a departmental call, Larry Horvath over at Laura, the director there, did mention surveyor testing and that they're looking into it. So clearly our advocacy with Dr. Gordon and Director Gordon has kind of made its way over to Laura. I know he said he was looking at it on joint provider, but I think maybe he's taking a more serious look at it now. We'll see what happens, but we do continue to advocate for that.
All right. MDHHS had a webinar yesterday on using the Binex Now cards. They reported a new website for HFA AFC reporting all results. I will send that link to Deanna.
Okay, thank you.
What is the date we need to start to enter POC testing to the NHSN website?
Actually, you're supposed to be doing it now, but they're giving everybody some leeway because everyone has to be upgraded to a level 3 access to NHSN. Off the top of my head, I don't remember the actual date for nursing homes, but I think it's late November. We can check into it. November 27th rings in my head, but please don't take that because off the top of my head, I don't remember.
Okay. Jackson County appears to be at 4% for county positivity rate. We have been concerned that the data is behind, and so the documented was last updated on the 6th. Just want to make sure we are not supposed to be on twice weekly testing at this point.
Well, even though there's a lag time for CMS, it's only CMS that's requiring twice weekly testing. Unless you have an outbreak, they encourage twice weekly testing. But it's only required for nursing homes who are at 10% positivity rate above. And the fact that it's a CMS only requirement and you are required to use the CMS color code to determine that The fact that they have a lag is perhaps problematic, but in terms of in terms of safety, but in terms of the requirements, you're not required to go to twice per week testing until you get a red code on that Excel file. So I wouldn't be concerned about that in terms of the requirements. If you believe that transmission in your local community is going up significantly, you can, of course, go to twice per week testing on your own. That's up to you.
What if it is a COVID positive resident in a HFA or AFC? Most don't have a dedicated unit.
Right now, if you don't have any alternatives, we believe that the protocol says that you could try to transfer them to a hospital with a swing bed. We all know that that doesn't work. The CRCs are not fully established. The regional hubs are pretty much full, and they were never intended to take HFA or AFC. So we have talked to the department about this dilemma over time, and I think that in reality and practice, most facilities go ahead and isolate the person in their facility as long as they're asymptomatic and they don't have any additional needs. If there is an issue beyond that, such as if you cannot really isolate them, or they might have some medical needs that are beyond your level of care, then if you contact us, we will help you contact the department, or you can contact the department directly to perhaps get an exception and find perhaps placement in another facility or in a regional hub. But we do freely admit that there are no great alternatives for HFAs and AFCs in this situation, and we have let the department know that I don't know how many times.
I was told November 20th was the date for entering into NHSN. This was from the speaker on the training on NHSN last Friday.
Right, thank you. As soon as I said the 27th, my brain said I think it might be the 20th, so thank you for that. Thank you for clarifying.
All right, it looks like that was the last question, so we can move on.
Okay, good. So moving on to the November 9th visitation FAQs. We are now up to version 4 of these. In doing this review, we've included some of the previous information blended with some of the new responses from the department in this version. We are very happy to note that the department has included a lot of the questions that we submitted finally in these new response. So one of the things we want to review that isn't brand new is a response to the question about whether or not facilities are absolutely required to allow visitation. That still seems a bit confusing to us. So the department is encouraging, and that's the word they use, they encourage providers to permit visitation when requirements are met. But they also give everyone flexibility to establish their own protocols to manage safe visitation. And at the same time, they note that you must comply with both federal and state requirements. So for nursing homes, at least, that seems contradictory to what CMS requires in terms of visitation. So we note that that continues to be a very gray area, and we will continue our conversations with the department about that. Again, visitors do not need to be monitored. The 15-minute close contact rule is intended to be a limit per day. So a visitor has a total 15-minute time limit daily, but they don't have to leave immediately after the end of that time. They can continue to visit at a safe distance. But remember that you as facilities have to manage all these visitors, and you have the ability to set some limits on how long your visitors can stay. This slide also includes one of our member questions. One of our members wanted to create a visiting room that would have a completely external entrance and would be sealed off from the resident side by a glass or plexiglass. So this would be kind of a type of window visit, but the visitor can also be indoors. They don't have to be outdoors. And the department says this is okay as long as the area is sealed with no common airspace between the compartments. So this is a way to do a window visit when there's inclement weather, if you have the structure and facility to make that happen. The department notes that surveyors are not subject to any visitor restriction, which we did know. But the department also finally responded that only essential work continues to be allowed when you're thinking about external contractors, structural changes, fire, plumbing, walls, painting, whatever. You can only do essential work if you're in a resident care area. So they can, these types of persons can continue to access resident care areas only when the work is absolutely necessary. And they did clarify that because we've asked several times. The department states that any outdoor space can be used for visitation. They find the use of tents most appropriate, but they do finally note that the tent cannot be closed on all sides. And we anticipated that because we do know that it needs to be a well-ventilated area, and a closed tent is not necessarily well-ventilated. They also confirmed that clergy would be allowed for end-of-life visits, but for any other type of visits, clergy would be considered a non-medical visitor. Clinical students, we did voice our concern about the fact that clinical students would not necessarily be allowed at all risk levels and regardless of outbreak status. And so the department came back and said that they can be allowed, but only if they're assisting you with your staffing needs. So if they're helping you address some staffing shortages, you can let them in to your facilities, regardless of what the community or county risk level is, and your facility outbreak status. Otherwise, they are considered as non-medical service providers in the same way and wouldn't be allowed in. The 72-hour testing time frame for visitors still holds. Facilities can choose to test more often if desired. And the department strongly recommended visitor testing in very well ventilated spaces and ideally outdoors. So I'm not sure how that's going to hold in terms of the weather, but that is one of the issues. So we've gone through this slide, so we were a slide behind before. Note that, no, stay there. Yes, thank you, Blake. Note that the link for the updated visitation guidance is at the bottom of this slide. So now we can move forward. So this week, the department put out updated rules for reimbursement for testing. And that includes those for HFAs and AFCs. AFCs, of course, being licensed for 13 or more persons. So they will reimburse lab costs related for PCR testing, but only when the lab partners with someone who accepts Medicaid and the lab is performing the tests. They will not reimburse any lab expenses, and we know that. That would be covered generally by Medicare or Medicaid. The lab is expected to bill for those services themselves. For HFAs and AFCs doing point of care tests, The state will reimburse $22.07 per test as they would for nursing homes. When the state is providing the testing supplies, of course, you can only bill the state for the specimen collection if you're doing a point of care test. The reimbursement rules for HFAs and AFCs are pretty straightforward, and they are at the link at the bottom of the slide. For nursing homes, the rules are a bit more complicated than for HFAs and AFCs. They will continue to reimburse any licensed nursing home for testing, and that includes hospice facilities that are also licensed as nursing homes as well, as long as you're incurring testing costs yourself, of course. Testing for Medicare and Medicaid residents in general should be billed to those insurers accordingly, unless the person is Medicare A. We all know that any testing would have to be covered under your per diem, and so the state will reimburse for that for nursing homes. So for initial admission testing or for symptoms, any of those kinds of things, those are usually PCR tests. They don't have to be, but they could be. Any testing should be billed to the corresponding insurance by the lab. But remember, again, the state will pay for tests for Medicare A as needed. You can also remember to bill Medicaid for any staff testing if they are covered, obviously, under Medicaid. So for point of care tests, only homes with CLIA certificates will be reimbursed, and the facilities are expected, again, to bill as needed. But remember, if the state's providing the test supplies and covering specimen collection, there should be little need to bill anyone for those tests. One of the things that the state included in this version of their reimbursement guidance is that MDHHS will not provide any lab-related reimbursement after a nursing home receives point-of-care tests, unless you're not using the state supplies or they have developed their own testing program. So there is, first of all, a huge expectation that facilities use the point-of-care tests that they have been provided. And if indeed you have been provided point-of-care tests, you might have a problem down the road if you're attempting to bill for lab-related reimbursement, which would be a PCR test. So if you've gotten supplies, you might have to show the state that you've used them. So the guidance continues to provide some of the parameters for reimbursement, and those are mostly unchanged. We have included them here as a reminder, and of course you have to fill out your testing reimbursement form, and the link, well, the email address to send them to is here. But there is really nothing new on this slide. This is all current material. Current, but also past material. Documentation. The documentation requirements are listed as the same for both HFAs and AFCs and nursing homes. So although I labeled this slide nursing home reimbursement, these requirements also pertain to HFAs and AFCs. You have to be able to support the costs related to testing. You have to have a log of all who were tested. But you also, and this piece is new in the guidance, you have to keep the associated visitor logs, those sign-in sheets, to support the need for visitor testing. And remember that they can take back any funds if you can't support the need for, or actually the provision of a test with the documentation. And again, the link for the nursing home guidance and the testing reimbursement form are here at the bottom of the page. Yesterday, the department provided us with an Excel file of point-of-care test distribution plans. There are 4 lists. There's actually 4 tabs in this Excel file that identify the providers who have been sent or about to receive testing supplies. One of the things to note is that if you're a SNF and you received a Quidel machine from the feds, you're going to get Binex cards. And you can see that a case of the BD supplies will give you 340 tests, and a case of the Binex cards will give you 640 tests. So nursing homes and HFAs were sent these tests yesterday. So if you haven't received them already, they should be coming very shortly. The AFC test supplies are meant to be distributed in the near future. They also reminded everyone to review the MDHHS guidance on antigen testing. So we've included that link here on the slide as well. And if you have any problems or questions about testing or supplies, you can contact MDHHS, and we've of course provided that email address here too. So lastly for today, we just wanted to tell everyone that although it's 11:15 or so right now, for any HFAs or AFCs that may have missed the first two registration periods to access the reporting, you can still do that today before noon. We did send out a reminder about this earlier this morning. Remember that reporting is required for licensed HFAs and any AFC that holds a license for 13 or more persons. And registering is important, is required and important, because it is through that process that MDHS is confirming your need to get testing supplies. So it's important for several reasons. And of course, the link to register until noon today is here. So now let's see if there's any more questions.
All right. I'm just going to hop right into the questions here. Forewarning, this one is kind of long. CMS rules for testing on positivity rate say you use the previous week's data to drive this week's testing. Do we use the same, or do we use the date the updated data came out, or the date the data reflects? Example, the website was just updated today but reflects data from the previous week 10/28 through 11/4. If over 10%, do we have to scramble to get twice weekly this week since the rate went up for data encompassing last week through 11/4? Or can we start twice weekly next week since the report just came out this week?
My remembering of the CMS guidance on this is that you must increase your testing to twice weekly immediately. If you are at a 10% right now, we can already know that that is data with a lag. The expectation is that you begin that immediately. However, the protocol for decreasing your testing rate when it goes down has another lag period in it, and I think that you have to wait at least another 2-week period to see whether or not your county positivity rate stays down. But I might have to check this, but I'm 95% sure that you have to increase your testing immediately. Now, you might want to look at your current schedule of your testing in order to do that, but you're supposed to act on that immediately.
We have painters painting walls in a resident area. They are tested along with the rest of the staff and wear masks. Is this okay, or would they be considered non-essential?
Off the top of my head and without any additional information, I think the department would consider them non-essential. Right now, technically, the department states that only contractors, construction, all those kinds of people are only allowed in resident areas for essential work.
Are LTC facility residents required to be tested if the risk level is at an E?
I don't know what an LPC is.
LTC.
Oh, long-term care?
Yeah.
Okay, so read the whole thing again. I'm sorry.
No, you're fine. Are LTC facility residents required to be tested if the risk level is at an E?
No, no. The only time that you have to test residents, of course, is if they have symptoms on admission and if you have an outbreak. So just because the local transmission around you might be high, unless you have an outbreak or an individual reason to do a test for a resident, you are not supposed to do that. In fact, they think it's just there's no evidence that it helps. Let's just say that. These are not the people who are moving in and out of the community. It's your staff that's moving in and out of the community
In the
in
FAQ,
general.
sorry. In the FAQ, the question is, are individuals who are in the facility for non-visitation purposes subject to the restrictions in the order? The answer is no. These individuals fall under the category of non-visitor and non-medical and are not subject to the restrictions established relative to the visitation in the order. Does this include testing of these types of folks?
When I first read that response, I thought that it was actually poorly written. And if I understand the question, first of all, I'm going to suggest that perhaps you send me that directly. You're going to have to test everyone according to that grid that came out. So I'm not sure what the question is beyond that. So I'm going to have to pass on this question because I think that there are some nuances here that I would have to think about, and please submit it to me directly.
Okay. Can you clarify about billing for tests? Once we get our machine, this means we cannot submit for reimbursement for the tests we are doing on our team members. Is this only for POC tests? We currently do PCR testing and we are submitting that for the swabbing, conducting the test, reimbursement, and send them to the lab. We are not using POC for our weekly staff testing. It is a cumbersome process to do 400 of those in one day, as you can only run a couple at a time.
Well, I don't have a 100% great answer for this because this new guidance just came out very recently, and it says that you can't be reimbursed for any PCR tests once you've been provided the supplies, unless you have an arrangement with a lab or you're doing something else. It doesn't really say what you have to do with the POC tests if you're not using them. It does say that you can bill for PCR tests if you have, I'm assuming, an arrangement. But I think what they want to make sure is that, number one, they're encouraging point of care testing, and especially for visitors. And number two, I think that if you're getting supplies, they don't want to pay twice for everything. So they don't want to give you point of care test supplies and then have you bill them for PCR testing. So I think that you should probably, on a case-by-case basis, negotiate this with the state. If you're not using your point of care test, I think you should probably let MDHHS know.
Please clarify clergy visits. Can a chaplain visit at non-end of life, or are these prohibited?
Clergy can visit, but they have the same requirements as other non-medical providers unless they are attending a person who's at end of life. So if you'll remember, end of life visits are always okay. There are no restrictions to them at all. Doesn't matter what your county positivity rate is, doesn't matter whether or not you have a facility outbreak. An end of life visit is always okay. And so a clergy member who is visiting for that purpose can always visit. However, for any other purposes, the guidance for non-medical service providers takes over.
We can bill for reimbursement collection for POC or AG cards, correct?
That's my understanding, yes.
Can you define visitor testing? Does this include family visits?
I don't know what is exactly meant by family visits, but yes, all visitors, if they meet one of the categories in the visitation guidance for weekly testing like staff, or if they are any other kind of visitor for what I would consider a family visit, they have to be tested up to 72 hours before their visit with results available.
The POC is most effective when someone is symptomatic, so not the best approach for our weekly staff testing. We've had negative POC on someone, example using for a new hire, and their PCR comes back positive that week.
Okay, so there's a wide range of opinion about POC tests and PCR tests. I think that when you're using them in a serial nature, point of care tests are considered fairly accurate. And the timing matters. So unless you're drawing that PCR test at the same time as the point of care test, there's always a possibility because whether or not a test is positive is often dependent on your viral load. So it's possible that there's some timing issues there between, the growth of a viral load before you do the PCR test. So I guess the idea about point of care tests is that unless you're using them for someone with symptoms, the idea is that you use them serially so that if indeed they're quick, right away, you can identify the positives right away, and you continue to test the negatives, and eventually you should find your people. There are going to be some gaps in that, but there are gaps with using PCR tests as well. So if you choose to use PCR tests, you can do that. There are pros and cons to both methods, really, if you think about it. But when you're doing visitor testing, it's going to be hard to do PCR tests for all the visitors that might be coming in eventually to your facilities if you're waiting, especially if you're waiting for more than 48 hours for a test result.
Do we need to report POC test results to both NHSN and MDHHS?
Yes, at this point, that's my understanding. The department still hasn't figured out what to do with all of that point of care NHSN testing. So our understanding is that nothing's changed for them, but we're hoping that somehow or other they'll coordinate this eventually.
If we received a POC machine, do we have to use it and the cards?
If you receive them from the state, if you're not using them, I would suggest you contact the state and let them know that. I don't know what they would do, but if they sent you tests, I think they're going to want to know if you're billing them for additional PCR tests, that there could be some problems there.
What would be the point in staff testing with a POC test if we need to follow up with a PCR per the guidelines?
You don't need to follow up with a PCR test, only in certain circumstances, if you're doing serial point of care testing. So if you're doing ongoing point of care testing over time, that is expected to find most of your positives. That's the goal, is that it's kind of a rapid shot and right away. You don't have to follow up every point of care test with a confirmatory test. So I would refer you to the CDC flow chart about when you do have to use a PCR confirmatory test. And it's basically when the results that you get don't fit the situation that you're in. But if you want to talk about this further, please email me, and we can talk about that. But you do not have to confirm every point of care test for serial testing. And if someone has symptoms and has a POC test and is positive, you don't have to confirm that either, because the likelihood of that person with symptoms being positive is pretty high.
All right. So it looks like that was our last question. So if anybody thinks of anything after this webinar has concluded, feel free to shoot an email over to Dalton, Deanna, or safeandcalm@leadingagemi.org, and we will make sure to get those questions answered for you. We would also like to thank everyone for re-registering. It looks like we're at our average attendance basically anyway, so it looks like it ended up working. So thank you for doing that, and hopefully that fixed the little bug as far as the invitations and we get the correct time moving forward. So now we would like to thank Deanna and Dalton, and we would also like to thank the 95 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. We will be holding our next Safe and Calm webinar this Friday, the 13th. I just realized it will be Friday the 13th at 11 a.m. Eastern Standard Time. So we will see you all then, and I hope everyone has a great rest of their Wednesday. Thank you.
Thank you, everyone. Take care. Have a good afternoon.